Hello, my name is Tiziano Barbui. Very glad to be with you today, talking for you about managing ET in 2021. The next. The agenda of my talk today will cover some points. The impact of WHO 2016 diagnostic classification on outcomes in ET, the IPSET thrombosis, the news on therapy of low intermediate risk patients, and the current results on the incidence of thrombosis in WHO ET. Next. Regarding the WHO 2016, there are four criteria, major criteria to be considered: platelet count, bone marrow morphology, you have to exclude BCR Abels on CML, PV, PMF, other myelodysplastic syndromes, or other myeloid neoplasms. Of course, you have to assess the presence of JAK2 CALR or PL mutation, and diagnosis requires meeting all the four criteria, or the first three criteria plus one of the minor criteria. So my patients sometimes are reluctant to do bone marrow biopsy, but I wanted to convince you that it's very necessary to do bone marrow biopsy in ET. The reasons are the following. Next. Next. You have to recognize ET from prefibrotic amelofibrosis. This distinction can be done only by the pathologist, who has some criteria to distinguish ET from prefibrotic amelofibrosis. It's important because there are many clinical implications connected with this distinction, and the survival is also different. We have, next, please. We have to recognize also ET distinct from PV when a patient with ET presents JAK2 positivity. You know, before the new classification by WHO, we consider also some patients with a polycythemia vera, even though at that time they were classified as ET, as initial early PMF, polycythemia vera. So in these cases, you have to separate the so-called true ET from early PV, because the hemoglobin levels can help you to distinguish these two entities. Next. So now there is a question. Given that the diagnosis of WHOET included also a fraction of prefibrotic amelofibrosis and the initial PV, which can have a different present outcomes and presentation, the bulk of our information are based on pre-WHO diagnostic criteria. Given these 2 points, a question can be, what is the current clinical epidemiology then, in terms of incidence of thrombosis, bleeding, evolution to myelofibrosis, acute leukemia, and survival in true essential thrombocythemia? As I told you, true essential thrombocythemia today includes only pure thrombocythemia and excluded initial phases of myelofibrosis, prefibrotic myelofibrosis, and initial phases of polycythemia vera. Next. We examined many patients, large series of patients with this new classification. And we realized that in terms of incident thrombotic complication, nothing changed in terms of thrombosis appearing 5, 10, 15 years after presentation. You see here ET, prefibrotic, or PV, they present a progressive increment of thrombosis, reaching the maximum for PV after 15 years. Next. The same was not true for bleeding. You see, bleeding is inferior in essential thrombocythemia as compared to prefibrotic myelofibrosis. Next. On the contrary, the incidence of myelofibrosis is very much different in ET as compared prefibrotic myelofibrosis or PV. You see, after 5 years after diagnosis, only 0.2% of ET present the transformation towards myelofibrosis. Less than 1% after 10 years. On the contrary, after 10 years, 12% of patients with prefibrotic myelofibrosis can have overt myelofibrosis, and around 20% of this present overt myelofibrosis after 15 years, only 9% in true ET. So the transformation into myelofibrosis is a rare event in true ET after 10 years. Next. The same is for acute leukemia transformation. The blastic phase after 5 years is 0.2%, less than 1% after 10 years, and 2% after 15 years. And you see here that after 10 years, so you cannot distinguish whether this percentage of patients developing acute leukemia are due to the intrinsic probability of the disease itself to transform, or can be due also, at least in part, to the drugs used to control essential thrombocythemia. Next. The IPSET thrombosis is the way to distinguish the risk of thrombosis that is one of the major events that occur during the natural history of patients with ET. We assess these risk factors as age over 60, cardiovascular risk factors, prior thrombosis, and JAK2 positivity. And we were able to incorporate these factors in a system called IPSET scoring system. And patients can be classified according to age, cardiovascular risk factor, prior thrombosis, or the presence of JAK2 positivity in 4 groups: very low, low risk, intermediate, or high-risk patients, according to the different combinations of these factors. Next, please. Ayo Luteferi published this important paper on essential thrombocythemia recently in New England Journal of Medicine. And he stressed the fact that guidelines, the National Comprehensive Cancer Network, NCCN guidelines, and European Leukemia Net guidelines, are based on this international prognostic score for essential thrombocythemia. And so that you distinguish very low, low, intermediate, and high risk. What is different here is the rate of thrombosis that is 0.4% in patients at a very low risk. So maybe you don't need aspirin here. You need aspirin only if you have a concomitant vascular symptoms. And in this case, you call this patient at low risk. Intermediate risk is a patient only for age, no prior thrombosis, JAK2 unmutated. So the absence of JAK2 mutated without prior thrombosis in a patient over 60 is not a patient with high risk, but is now classified as intermediate risk, so that not in only patients, just for age, need to be treated with a cytoreductive therapy. On the contrary, you have here that high-risk patients include age plus previous thrombosis or cardiovascular risk factor and prior events. Aspirin is used in all this category. On the contrary, cytoreductive therapy is recommended only at the moment, only in high-risk patients. Next, please. Concerning aspirin, we don't have randomized clinical trials. We have to be very cautious in prescribing aspirin in our patients with ET if the patient is CALR mutated, because the risk of bleeding is very elevated. On the contrary, in JAK2 mutated patients, you have to give aspirin because aspirin can produce a reduction of incidence on thrombosis without effects on the risk of bleeding. On the contrary, don't use aspirin in prefibrotic amelofibrosis because aspirin increases the risk of bleeding. Next, please. Now we are exploring whether it's enough to give only one aspirin a day to abolish the functionality of the patient. You have to consider different effects of regimens of aspirin on serum thromboxane B2. Serum thromboxane is released by the platelets once they are activated. But the platelets coming from a normal person, a normal individual with a normal megakaryopoiesis, if you give in this patient only one aspirin a day, you abolish the production of serum thromboxane so that you eliminate a source coming from the platelets of a procoagulant factor. On the contrary, if a patient as an accelerated megakaryopoiesis, meaning a patient with essential thrombocythemia or a patient with other MPNs, they have increased immature platelet counts. In this case, one aspirin a day is able to abolish the production of thromboxane B2 only for 12 hours. And the patient has an exposition to thromboxane, as I said, a prothrombotic substance coming from platelets for the subsequent 12 hours. So the hypothesis is we have to give 2 aspirin a day if you want to abolish the production of thromboxane. Now a clinical trial is going on in Italy to assess whether to abolish the thromboxane is associated also with a significant reduction of thrombosis. Next. So talking about the platelet number, are platelet levels up to 1.5 million risk factors for thrombosis? This is a very frequent asked question by patients. And many years ago, 23 years ago, we published a paper saying that patients with levels of patients with levels of platelets up to 1.5 million, they do not need to be treated with a cytoreduction because this number is not associated with thrombosis, is associated with bleeding. So you have not to give aspirin in these patients. But this was not demonstrated in a formal randomized clinical trial. Tom Pearson, who is a pioneer in MPN knowledge, he's an English researcher, and he comments our paper saying that this is relevant to design our PT1 clinical trials. And I have to say, next please, that very recently they published the results of this trial. This trial was a randomized clinical trial. Half of these patients were treated with only aspirin plus hydroxyurea, and the other half was treated only with aspirin. And they saw that aspirin was not able to reduce the thrombosis or death in these patients. The overall survival was the same. The transformation to myelofibrosis, acute leukemia, or myelodysplasia was exactly the same. The only difference in favor of hydroxyurea was seen for transformation to overt polycythemia vera. But once again, I have to say that these patients were not classified according to WHO classification I told you before in the previous slides. Next one. So they concluded here, go back please. They concluded here, patients with age less than 60 without other clinical indications for treatment, such as thrombosis or hemorrhages, who have a platelet count up to 1.5 million should not receive cytoreductive therapy. This is an important take-home message. Next. What about leukocytosis? We did recently a meta-analysis on that, and we realized that this can be an issue for patients with essential thrombocythemia, in the sense that patients having leukocytosis over 15,000 can have a tendency to develop, together with thrombocytes number, together with high thrombocyte number, can have thrombotic events. But which type of thrombosis? Not venous thrombosis, but only arterial thrombosis. Next, please. So that we move to high-risk patients. NCCN, as I told you, accepted our IPSET thrombosis as a criterion to differentiate treatments in essential thrombocythemia. High-risk patients then are patients with a history of prior thrombosis at any age, or age over 60 years with JAK2 mutation. First-line treatment in these patients is hydroxyurea associated with aspirin. Other recommended in first line can be PEG interferon alpha or anagrelide. Next. However, concerning anagrelide, ELN recommendations do not agree completely with NCCN, because even though the majority of the experts, this panel of experts, indicated anagrelide as an appropriate choice for first-line therapy in ET, the panel did not reach a consensus or recommended the agent in this setting. Next, please. On the contrary, pegylated interferon should be used in patients who presented intolerant or resistant to hydroxyurea. This has been demonstrated in a clinical trial performed by the MPD consortium. Next. Concerning ruxolitinib, there was a phase 2 study done by Serge Vertovsek in 2014, and they concluded that hydroxyurea-resistant patients can achieve clinically meaningful, durable reduction in platelets and white blood cells, important this, and improvement in ET-related symptoms. However, in the clinical trial, randomized clinical trial done by Claire Harrison and published in Blood in 2017, ruxolitinib was not able to reduce thrombosis of hemorrhage or transformation towards amelofibrosis. The only activity efficacy was seen to improve disease-related symptoms. Next. So, at the end, I have to say that today, after 2005 or before 2005, unfortunately, I have to say that we did not accomplish important progresses in the reduction of thrombosis as judged by this rate seen in low, intermediate, and high-risk patients in essential thrombocythemia diagnosed according to WHO classification. The last slide is a summary slide, please. Special attention then should be done to bone marrow morphology. Every patient should be submitted to bone marrow morphology before diagnosis and before starting therapy. It's important because you have to distinguish ET from prefibrotic amelofibrosis and the initial phases of polycythemia vera, because the bleeding, survival, myelofibrosis is different in true ET. Life-shortening morbidities in ET are largely due to vascular events. The revised IPSET thrombosis is the guide for choosing therapy, both in clinical practice and in clinical trials, and thrombosis and bleeding, unfortunately, remain unmet clinical need, and the rigorous randomized clinical trial should be done and are warranted. Thank you very much for listening.